Assalamu alaikum, everybody. I must, first of all, thank Dr. Shaheen for inviting me to give this talk. And secondly, to Health Asia for organizing this program. And to each and every member of the audience for staying here so late. So, inshallah ta'ala, hopefully you will gain something from the presentations, from the wonderful presentations that we've heard so far. So now my topic today is menopause and medications used during menopause. So as you all very well know that when a woman reaches the age of menopause, many women go through menopause with no symptoms, with no problems, and they just sail through. But there is a proportion of women who require help, and some of them actually require medication. And now in this day and age, we have a very vast array of medications which can be given to menopausal women to improve their quality of life. So, so basically, let's move on. Okay. So I think at the outset we have to understand, just as my previous speaker has mentioned, that lifestyle changes play a very important role in the management of menopause. And these lifestyle changes include some kind of practices for mood elevation, which can be spiritual or physical or mental. At the same time, changes in diet. At the same time, changes in the exercise level. However, medications, like I said, can be used to alleviate certain symptoms. And these symptoms include hot flashes, vaginal dryness, and most important, preventing bone loss. So we all know, and we are well aware of the fact that the ovaries are diminishing their function, as a result of which the estrogenic hormones and the progesterogenic hormones are diminished, as a result of which changes take place, physiological changes take place in almost each and every part of the woman's body, which includes the bladder, which includes the uterus, the vagina, her skin, her breast, and even her brain. So, I want to hurry through these slides so that we can move to the main slides. So, as we all understand so clearly that menopause takes place because of the changes in the hormone levels, so naturally, when medications and medical management of menopause came into being as early as the 1950s and the 1960s, the most natural medication that was used for helping women to go through menopause was hormone replacement. And these hormone replacement were used to treat hot flashes as well as vaginal dryness. And it became a very popular form of treatment, so much so that women used to or believed that it was something that would make them young and keep them young. So, जैसे कहते हैं कि जवानी का एक तोला, it is like something like that, कि you are taking something which is going to keep you young. And this was heavily propagated by the media as well. So, but however, it was soon felt that by the 1970s, it was felt that estrogen alone was giving rise to an increased risk of endometrial cancer. And so, as the risk of endometrial cancer grew, it was recognized that if you gave a woman estrogen without giving her progesterone, then she ran the risk of breast cancer and mostly endometrial cancer. So then, as this came into being, then the flavor of the hormone replacement treatment became less palatable, and so much so that women started looking towards, the phytoestrogens, etc., as also one of the ways in which you could bring in, your quality of life, etc. In 2002, the Women's Health Initiative was a very huge and major study which was partly supported by the National Institute of Health in the United States of America. And that study by itself brought a very significant shift in the use of hormone replacement therapy. This study found that combined estrogen and progesterone HRT was linked to the increased risk of stroke, heart disease, and breast cancer. So this led to widespread media attention and a dramatic drop in HRT prescriptions. So basically now we have to understand that what are the kind of medications we have, which we are using in the current day practice for medications during menopause. So the leading form is again estrogen, and the common forms include conjugated estrogen, which is the more naturally resembling estrogen, and estradiol, as well as ethinyl estradiol. So ethinyl estradiol is a totally synthetic form of estrogen, and as far as possible, we should try to adopt those kind of medications which are more natural. So conjugated estrogens are more natural as compared to synthetic. And these are used mostly in women who don't have a uterus, so they are not running the risk of endometrial cancer. Combined estrogen and progesterone therapy is used for women with an intact uterus to protect against endometrial cancer caused by unopposed estrogen. And the common progestogens which are included along with either the conjugated estrogen or the synthetic estrogen include medroxyprogesterone acetate and norethindrone acetate or micronized progesterone. What are the relative contraindications to using HRT? If a woman herself has a history of breast cancer or a very close family history, first degree relative history of breast cancer, if she has a history of thromboembolic disorder, if she has hyperlipidemia or undiagnosed vaginal bleeding, these are relative contraindications. And मुझे लग रहा है ये दो भी एक साथ चल रहे हैं. Other relative contraindications include history of active liver disease, okay, now so having spoken about the HRT, now we move on to a different kind of medications which are also used as a treatment of women who are having menopausal symptoms or who want to have some treatment during menopause. Now there's a huge group of drugs called the selective estrogen receptor modulators. The short form is called SIRMs. And common examples, the ones that I have asterisked, there's an asterisk on top of that. These are available in Pakistan also. And these include raloxifene, ospenifene, as well as Menorin, which is the Excel produced, labeled drug. So these non-hormonal drugs mimic or block estrogen in different tissues and can be used as an alternative to HRT. The mechanism of action of SIRM is that it relies on the tissue-selective estrogen receptor agonist or antagonistic activity. And these drugs do not have the same level of effect as estrogen. So by blocking the estrogen from connecting with breast cancer cells and keeping the cells from multiplying, it acts like estrogen, boosting estrogen levels in the bones, preventing osteoporosis. The advantages of using SIRMs include improving bone health, preventing breast cancer, preventing the risk of endometrial cancer and cardiovascular benefits. The disadvantages include having vasomotor symptoms, risk of blood clots, and potential for leg cramps, and limited symptom relief. Another drug that is available and is not an HRT are gonadomimetics, such as tibolone. It is a synthetic steroid which has estrogenic, progesterogenic, and androgenic effects and is used for hot flashes and osteoporosis. It is also believed to increase the libido in postmenopausal women. There are many advantages and disadvantages of gonadomimetics, which are very similar to the SIRMs. Okay, so apart from these drugs that I've just spoken about, like for example the HRT and the SIRMs, the other group of drugs that can be used in menopausal women include the non-hormonal medications as antidepressants. So the SSRIs, which are actually the serotonin reuptake inhibitor and the serotonin and norepinephrine reuptake inhibitor, are sometimes used for the treatment of depression, mood changes, and some other common conditions. And these medications are available as Paxil or Prozac. Gabapentin is another drug which is useful for hot flashes. And it acts at the central level, and it is an anticonvulsant basically, but it is used to reduce hot flashes and is also available locally in Pakistan. Clonidine is not available. Vaginal estrogen therapy is a very useful and a very practical way to manage vaginal atrophy. And it does not have to be used for long periods of time. Women can use it for up to 2 months, very sparingly, and then if need be, they can repeat the treatment after 6 months. A very important group of drugs are the bisphosphonates. The bisphosphonates are a group of drugs that is used for improving the bone health and preventing osteoporosis. Calcium and vitamin D supplementation also has a role to play. So bisphosphonates act very locally on the bone level and increase the bone strength. So there are certain alternative therapies which are also available and very popular, and these include phytoestrogens or the plant-based estrogens, black cohosh, which is a kind of a mushroom, vitamin E, and many of these are very available over the counter and easily available, and women like to use them because they are natural substances. So the current perspective on hormone replacement therapy is that the risk and the benefit of HRT continue to be the subject of ongoing research and debate. And it is now prescribed more cautiously with an emphasis on individualized treatment. It is recommended for short-term symptom relief and in cases where the benefits outweigh the risks, particularly for women experiencing severe vasomotor symptoms and those at risk of osteoporosis. The NICE guideline, which was updated in 2019, recommends that women should be offered hormone replacement therapy for hot flushes and night sweats after discussing risk and benefit. It can also be used for low mood that occurs as a result of menopause, and consider cognitive behavioral therapy to alleviate mood and anxiety. So estrogen-only HRT has little or no increased risk of breast cancer, while HRT with estrogen and progesterone can be associated with an increase in the risk of breast cancer. Specifically, it says there will be 17 more cases of breast cancer per 1,000 women, menopausal women in current HRT users over 7.5 years. So NICE guidelines understand that HRT does not increase cardiovascular risk when started in women aged under 60 years. And it does not affect the risk of dying from cardiovascular disease. It also ensures that women with cardiovascular risk factors are not automatically excluded from this group of drugs. The International Menopause Society Position Statement 2017 also echoes the same findings of the same guidelines as the NICE guidelines. They also say that HRT can be initiated in menopausal women at a risk of fracture or osteoporosis before 60 years of age or within 10 years after menopause. HRT, including tibolone and the combination of conjugated equine estrogens and the SIRMs, are the most effective management of patients for vasomotor symptoms and for urogenital atrophy. Okay. So for those of you who may be interested in listening to this talk again, I will be publishing this talk on my YouTube channel called Acon Learning, and you can, by Monday, so you can then see my talk over there also and share my talk with your colleagues also. Thank you very much.